First thing we need to cover is a basic overview of the anatomy of the meninges. The spinal column, pelvis, and meninges act as a singular synchronous functioning unit. Right? Synchronous, same as synchronized. Right? Because the meninges attach at the tailbone, go up the filum terminale, and then go around the spinal cord and brain, up through the bottom of your skull and around your brain, what you have is the entire spinal column working as a single unit. You don't have a neck, a back, and a low back. It all works together because the meninges act as a big rubber band. They act as a single synchronized functioning unit, which means that you don't have a neck, a back, and a low back. Everything works together, and that's going to become apparent here on the x-rays. Now, what we have here is we have a standing and sitting full spine set of films, which are all taken at the same time. There's about 4 or 5 minutes between them. The first film, breathe in, breathe out, relax, let your body slump. So you have the standing lateral. Next one, breathe in, breathe out, relax, let your body slump, standing AP. And then sitting on a flat stool. Patient's down, arms are up, breathe in, breathe out, relax, let your body slump. Then we turn them around, spread the legs about 5 or 6 inches so you can see the symphysis pubis. They're relaxed, breathe in, breathe out, relax, let your body slump. And here we have those 4 films. The patient is not doing anything special. We are not positioning them. They are letting them relax and slump to go where they are most mechanically efficient. I don't know if you realize that when you let the person relax, they're not using their muscles. So you're looking at where their mechanical leverage is most efficient for the skeleton. Now, to explode a few myths in bodywork, all right, there's the myth that you need to remold the ligaments in order to change the cervical curve. Well, if you look here, you have a flat cervical curve. This is with the patient standing. Here, you have a perfect lordosis. As you can see, here the curve is flat. All right, if you measure it out right at C5 and C2, as they say, all right, you can come up with a 15-degree curve, but between there, it's actually going the other way. All right, so it sort of comes up a little bit, goes the other way, and then C2 is back a little bit, measures out 15 degrees. But that's only because otherwise they'd be looking at the floor. Here, all right, you make the same measurements according to the way Harrison says. It's the exact 43 degrees he talks about as a perfect cervical curve. And as you could see, it's a nice smooth curve all the way up. So sitting, it's perfect. Standing, it's reversed or flat, depending upon which part of the neck you take a look at. And all the patient's doing is going from standing to sitting. So, if you're trying to fix this flat cervical curve, especially if you're adjusting the person sitting down, what are you working on? It changes. Also, because of the way the meninges work, you can look here. You see here you have a lumbar lordosis. You could see the lumbar spine is fine. If anything, it's a little bit hyperlordotic, too much, as L3 is in front of the gravity line. Here, you can see there's just a tiny bit of a lordosis at L5, S1. After that, it's actually reversed all the way up to T12. So while you have a perfect lordosis here, this is reversed. While you have a perfect lordosis here, this is reversed. In this particular set, they're working in concert. There's also a change in the curve of the thoracic spine, but that's covered on my website and a couple other places in the standing and sitting x-ray primer. And you can look there for that information. Now, you'll also see when this cervical curve is flat, in the standing picture, you can see there's a slight scoliosis in the cervical spine here, but it's tilted out to the side. When you have a perfect cervical curve here on the lateral, the cervical spine here, though off center, is perfectly straight. All right? In the thoracic spine, you have a big flat spot, a bend, another flat spot, and another bend. And then at the top, as it goes into the cervical spine, it's flat. All right? People might think this is a good kyphosis, but it's not. All right? And you'll notice you have the scoliosis here. All right? Here, you have a more smooth curve for the kyphosis, and you'll notice that you have a better looking spine here. There's less lateral curvature. The lumbar spine, you have too much of a lordosis here, and you've got a 23-degree scoliosis, and you can see there's a bunch of rotation there. All right? Here, you've got a little bit of a lordosis, and then it reverses, and you can see here there's much less rotation, but still you have a scoliosis here, but it's only 15 degrees. So which one's compensating for what, which one's out of place, and which one do you need to fix? Unless you do a complete mechanical analysis of the whole spine as a single synchronized functioning unit, you don't know. We're not going to do that here, but we have. So as far as changing the curve and having to remold the ligaments or having to do muscle work, it's gone. You don't have to do that. This one set of x-rays blows all those theories out of the water. There's a favorite quote that engineers use to talk about scientists who have theories on how things go together. And that is, the greatest tragedy in science is the slaying of a beautiful theory by an ugly fact. I have many sets of film. I brought a few of them today. We didn't know which ones would show up best on the camera, that explode those theories. Now, another thing you have to look at is the fact that bodies are not made to be able to self-correct the position of every bone that goes out of place. For example, if you have a vertebra that goes out of place left or right in the body, you have muscles on the sides that can pull them left or right. Now, there's all sorts of arguments. You can't pull a segment. You can't pull a singular one. We're not talking about that, all right, because you can. Now, we're also not talking about whether they work or not. We're talking about whether there's a muscle physically there that can pull them laterally. And there are. You can look in any anatomy book. If a vertebra slips posterior, going that way, you have muscles that can pull anterior. If you take a look at the anatomy, down here, you have the psoas. All right? Every time you're sitting down, it attaches from the spine to something in front of the spine. As you stand up, it pulls that forward. But that's only up to about L2. From L3 up to somewhere in the mid-thoracics, depending upon who the person is and where their body is attached, if you pinch your nose shut, close your mouth, and suck in like that, you'll feel the diaphragm pull those vertebrae anterior. And above that, from here to here, if you put your head slightly in flexion, palm on your forehead and flex against resistance, you can pull the rest of them anterior. So if you have a vertebra that goes posterior in your body, you have muscles that can pull anterior. Now, if you have a vertebra that goes anterior, and please, all the people that said vertebrae don't go anterior because the ligaments hold everything else, those ligaments are there to prevent them to go posterior too. People that say it can't go forward because of the facets, well, the facets on the bottom go like this, the facets on the top go like this, so it shouldn't be able to move anterior or posterior. None of those arguments hold water. Also, you can take somebody, lay them down, do a big P to A adjustment on them, all of a sudden they'll get up, they can't breathe well because you force something anterior. That argument just doesn't hold water. Now, if a vertebra does go anterior, there are no muscles back here, no muscles here, that pull that way. All the muscles are in the same plane as the back. Because all the muscles are in the same plane in the back, as the back, they can pull inferior, superior, and they can pull left and right, and on all sorts of angles. But they can't pull vertebrae posterior. So the one thing your body cannot self-correct in the spine is a bone out of place anterior, vertebra out of place anterior. That you need somebody else to correct for you. Now, of course, vertebrae don't go anterior. They go anterior left, anterior right, anterior in some sort of flexion, extension, rotation. But if you take care of the anterior component, your body can handle the rest. All right. But where? Well, that's what you learn in Advanced BioStructural Correction. Now, here you have on these x-rays enough data to know that a lot of theories are down the tubes. The muscle theory, the ligament theory are all down the tubes. Because just from going standing to sitting, you see more changes here than you're supposed to be able to see because of the way the ligaments are frozen. Your body is not a solid object like that. It moves quite a bit. Before we go on, I want to cover one more thing because people make a mistake with this. They think there must be muscles that pull vertebra posterior, otherwise the body couldn't stay up. If you take this as the spine, anterior is here, posterior is here, right? If you slide a vertebra anterior, you don't have any muscles that pull this way, but you do have muscles that pull this up and down. So as you pull down on this vertebra trying to pull it backward, it rotates into extension. You'll notice the bottom of this vertebra here actually goes more anterior while the top comes posterior. You can lean your body backward, but you cannot pull vertebrae posterior as you can go sideways or as you can pull them forward, as we discussed. Okay, one thing to cover is where pain occurs in the body. Pain does not occur where a vertebra goes anterior, where a bone goes out of place in a direction the body can't self-correct. The reason is that as soon as that thing goes forward, your body can't deal with it anymore. It has to shift the weight to somewhere else. An example would be like this. If I can have your help, please. Good. If I take Pam's arm, this is Pam, by the way. If I take Pam's arm and I twist it, it starts to hurt. In order not to hurt here and take the pressure off, she raises her shoulder. At the end of the day, she's mostly going to have pain up here at her shoulder because she's holding it up. If I twist over here, you can see she immediately lets the pressure off her shoulder because now I'm taking the pain here, now I'm taking the pressure here. The problem is, at the end of the day, she's going to have damage here. So she has a choice between the shoulder damage or the arm damage. And we'll fix that for you later. All right? So the place you have the pain is not where the primary subluxation or the primary bone out of place that you can't correct is. It's where you shift the weight to. That could be your knee, that could be your ankle. That's why when you start treating people, immediately problems disappear as you treat them up here in the legs, in the arms, and everywhere else. We just did a show the other day, or a presentation for one of the New York Chiropractic Council meetings. And I believe it was Dr. Shaw's wife couldn't bend more than this because her knees hurt so much she was having trouble. All we did was the first rib maneuver, which brought her body back, and immediately she could squat all the way down, so her buttocks hit her heels. This is why. As you treat a patient's body, what happens is you bring the vertebrae that are stuck forward back into place. Their mechanics improve. What happens is they now have to go out to the next place the body goes forward, because it doesn't just go forward and hang there. It goes forward and then the body leans backward to compensate. So as their mechanics improves, they literally go forward, get to the injury position, and then you come along and fix this, and then they go to the next one and the next one and the next one. Literally, you will see in this person's example, you will see this curve come around to the side, actually get worse on top, or may come around to the side and get smaller on top first as it gets worse here. There's a couple of things that will determine which way that happens, and it's not your adjusting, it's the way the mechanical stress is set up. In this person in particular, and we don't have her follow-up views yet, But in this person in particular, you can see L5 is actually going this way underneath L4, which is going this way. It's more noticeable here, and you could tell here because it goes forward while everything else is reversed in the lumbar curve. Literally what's going to happen as this person unwinds in 3 dimensions is this is going to come all the way around to the other side. She'll actually have a curve, a C curve going the other way just before she comes into recovery where this thing straightens out completely. It's neat to watch. Now, the other thing to know is when a person's body is unwinding and going backward, they will literally not notice their body. They won't feel good. They just won't notice their body. There'll be nothing for them to notice. As they come around and go forward, when they're 50% forward to the next position that they're unwinding, they'll come in and tell you, this is bugging me, doc. You treat them. Their mechanics get better. Because their mechanics are better, they can actually unwind farther forward. Because they can go farther forward, they're farther into the injury position. They will come in and they will go, doc, this thing is really bugging me. Then what's going to happen is you're going to treat them. They're going to get even a little bit better. Because they're better mechanically, they can go farther into the injury position. They're going to get like 80, 85% there, and they're going to get even closer to you, and they're going to go, hey, doc, this thing is really bugging me. Then you're going to treat them. They're going to improve. Then they can go really far forward. When they're like 80, 90%, 90, 95% forward, they're going to come in. They're going to want to get real close to you, and they're going to go, doc, are you going to do something about this? You are going to treat them. This thing will come back, and it'll disappear. They may or may not notice a big deal. Usually they just take a deep breath and that's it. They leave. The next visit, they come in, but they don't complain. And you go, well, how's that thing you were complaining about? And they go, what thing? Because once you fix it, it's gone, and they mostly don't even remember that it's there. They expect you to be able to do your job, and with Advanced BioStructural Correction, you'll be able to do your job.